So today I'm going to tell you about Muddis. Muddis is a cat and he's one of my favourite patients. And we're going to talk about his journey through limbic encephalitis. Yes, it's a disease with a horrible name, and it was immortalised in a film and book called Brain on Fire. And I'm going to tell you about how Muddis battled this disease and his diagnosis and treatment. Muddis came into my life 1 year ago, and this week marks the 1 year anniversary of his veterinary stay, and I'd like to tell you his story. So Muddis was considered a very ordinary cat. He was 10 years old. He's a male neutered domestic shorthaired. He's considered extremely friendly with humans. He was a single cat. He came from rescue about 5 years previously. He's never been outside the UK, which is important for those of you who are wondering, because the UK has a lack of some infectious diseases. He eats a regular wet and dry cat food diet. He's a hunter. He enjoys going outside, and he always eats his prey, or he often eats his prey. He's up to date with all his preventative health care, like his vaccines and his wormer, and he's otherwise a very normal but very special cat. And on the first day, his caregivers woke up to him yowling at 5 a.m. Now, he could be a talkative cat, but this was very different to his normal sound. And what's more, his bed was soaked in saliva. He seemed very unsettled and very easily startled. And so, recognizing that this wasn't normal for him, his caregivers took him to the emergency vet. And they found took some regular blood work, which was normal. Didn't really find anything on clinical examination. But he continued to have these episodes, which we're seeing here. He was described as wobbly. He had facial twitching, hypersalivation, dilated pupils. He was yowling and hissing, and he had times where he seemed to be involuntary urinating and defecating. And we can just see in this video here, he's kind of looking around as if there's something there. There is drool coming down from his mouth, and he isn't really very responsive to his surroundings. Doesn't really look like he's entirely present, even though he looks like he's looking at something. So this continued. It's now day 2, and the episodes are getting much more frequent and now occurring every 5 minutes. He's no longer at all responsive to his owners. He seems completely unaware of his surroundings. He has a fever. He's pyrexic, and he goes back to the vets, and they treat him for a possible toxic encephalopathy, which was not a bad call, given that cats can get into things and eat things or eat poisoned prey. And they gave him some anti-seizure drugs. And this is Muddis here on day 2. You can see this sort of slight head wobble, the salivation. Doesn't seem to be aware of his surroundings. And on day 3, he was referred to where I work, which is Weir Referrals. It's a specialised neurology and other disciplines, an emergency hospital. And I saw Muddis, and I suspected that he had temporal lobe seizures. And what do I mean by that? Well, and I should say this is seizure symptoms. It is humans, because of course dogs don't and cats don't have symptoms. They have signs, because symptoms are subjective. And so this is what is described by humans with the different seizure types. And of course, we can use that to try and infer what's going on in animals. So in the frontal lobe, we get a loss of motor control, change in behavior, change in language in humans. Parietal lobe, very difficult to tell a diagnosis of parietal lobe seizures in animals, because this is very sensory phenomenon like numbness and burning and cold. Occipital lobe, humans describe seeing multicolored shapes, circles, flashes, maybe having a temporal loss of vision, maybe other things like hallucinations. And then we have temporal lobe, where you can experience odd smells and tastes, have buzzing or ringing in the ears. The temporal lobe is where you have your hearing center in your brain. You may experience fear or panic, feelings of deja vu, and you may even have abdominal discomfort. And based on quite a lot of literature that is listed down here, I think we can recognize 6 stages of a feline temporal lobe seizure. So stage 1 is kind of attention, looking up and around, sniffing. Stage 2 is a kind of motionless staring, a motor arrest. Stage 3 is autonomic manifestations such as salivation and mydriasis, so the autonomic nervous system being activated. Stage 4 is orofacial automatisms, things like lip smacking, facial twitching, chewing, swallowing, and eye blinking. Stage 5 is a tonic extension of the opposite to the seizure focus, forepaw, head nodding and head turning. And then stage 6 is secondary generalizing, going into a tonic clonic seizure. And feline limbic encephalitis has been recognized over probably over a decade now. And the human equivalent has been immortalized in the book Brain on Fire, which was turned into a film. And I suggest that if you're interested in epilepsy, that you read that wonderful book, because it really gives an amazing description of what it's like to experience epilepsy, both from the subjective and also from the author actually observed herself on video, because there's a lot of memory or loss associated with the time. What I've noticed with these cats is they have a sort of initial behavioural change. So they have typically unusual vocalization, aggression. You know, remember Muddis, I don't think he was ever aggressive, but he was a particularly friendly cat. Signs suggesting anxiety and fear. Then they get, in my experience, quite often an evidence of a pyrexia. Perhaps that's associated with an infectious cause, or perhaps it's due to damage to that temperature control centers in the brain. And then after a few days to a couple of weeks, the seizures start. And it can be quite a long, there have been some months of behavioral changes described, and certainly Susanna in this book described months of having visions and other unusual manifestations. And then they start with these focal seizures, with these orofacial automatisms, so these orofacial seizures, facial twitching, lip smacking, chewing, licking and swallowing. And then they have behaviour as if they're watching something, typically with dilated pupils. And they're not normal between the seizures. This is quite different from idiopathic epilepsy, so they often are described as being wobbly, or ataxic, rapidly running, circling, apparent blindness, deafness, weakness, drinking a lot, eating a lot. I mean, very, very variable between each cat, and rarely dog. It's much more a cat disease, this. And I've found that neurological examination can be extremely difficult because the cat is so agitated and, completely unlike their normal calm disposition. So here's another example. It's a 2-year-old cat. She's suspected, and you can see that she has these widely dilated pupils, and she looks like she's watching or searching. And I've also noticed that this slight protrusion is not uncommon during that stage. Here's another little chap. He's a 1-year-old male Bengal, and he had a 10-day history of a behavioural change described as being vocal and jumpier, urinating outside the tray, eating more and faster than usual. And then he developed these focal seizures with facial twitching that became almost continuous with circling to the left. So how do you make the diagnosis? Well, you may find MRI changes, and this is a diagram kind of drawn by my son, really to show the limbic system, and also the frontal regions that are associated with behavior. And what we're looking for in these animals is changes in the mesial temporal lobe and the hippocampus, which and the amygdala, which is highlighted here in purple. And so I would refer you to the epilepsy MRI protocol, which I did a little lecture on a few weeks ago, for getting the best imaging in those. But I can show you here that this is a parasagittal image, and you can see the hippocampus is classically curled, meant to look like the curled tail of a seahorse. And I think, given a little bit of imagination, you can just see that this might be that curled tail of the seahorse, and then this is the seahorse coming up here. So this is edema right through that hippocampal region there. And then we have these transverse images, and we see this is the lateral temporal lobe, and here is the mesial temporal lobe, and we can see that we have high signal edema, inflammation right through this mesial temporal, medial temporal lobe, but the lateral temporal lobe is comparatively spared. And then again in this dorsal or coronal, as they call it in humans view, we can again see the edema through the scrolled area of the hippocampus. So what did Muddis look like? Here are some of his images. So we have this T2 weighted image here, and we can see that his edema and changes actually involves the mesotemporal lobe and actually kind of extends a little bit round the bottom, possibly going into the lateral temporal lobe. Certainly looks possibly swollen through here. And then we see that he actually has contrast enhancement through this region as well, and it's bilateral changes. He had a cerebral spinal fluid analysis, and not unremarkably with this disease, he had a mild mononuclear pleocytosis. It's usually not very dramatic, especially when you see that MRI, you expect it to be hooching with white blood cells, but it's usually not very dramatic, and I'll explain why that is later. So it's just 20, 4 times normal, and a raised protein. This was due to an albuminic cytological dissociation, which basically means that the albumin was probably normal, and this is a increased globulin. It could be that there's leak of albumin through a leaky blood-brain barrier, but it's much more likely in this case that this is globulin, this is immunoglobulin. So this basically, this confirmed an inflammatory process, but is not, and it's consistent with limbic encephalitis, but not absolutely diagnostic because it's a pretty non-specific change. So you're probably, or possibly wondering at this stage, what is limbic encephalitis? Well, it is one of the autoimmune encephalitises, where you have an immune-mediated response against something really quite specific. So it is not like the meningoencephalomyelitis of an unknown origin, which, although we still haven't absolutely proven what the target inflammation is, it is more likely to be a protein that is pretty diffuse through the nervous system. This really comes down to cellular targets. And we can divide it into 3 types. So the first is autoantibodies against cell surface synaptic antigens and receptors. So just think receptor. So things like the NMDA receptor, the AMPA receptor, but of course all glutamate receptors. The other glutamate receptor, which is the metabolotropic glutamate receptor, or the GABA B receptor. So if you knock out some of these receptors, then you can make the cells more susceptible to excitotoxicity damage. You can have autoantibodies against the proteins that stabilize the voltage-gated potassium channel complex into that cell membrane. So these are proteins that are stabling that complex, and I've just drawn here, or at least my son has drawn here, a neuron which is excitatory to the hippocampal neuron, releasing glutamate, and this is stabilized by this voltage-gated, or activates these voltage-gated channel complex, which are stabilized by the Caspar and this leucine-rich glioma inactivated protein. And the most common type of limbic encephalitis in cats is against here, and there is investigation to see whether or not there is action against this one here. And then the final one is autoantibodies against enzymes that catalyze the formation of neurotransmitters. So for example, glutamate is converted by glutamic acid decarboxylase, which is shortened to GAD, into GABA. Glutamate is an excitatory neurotransmitter and GABA is an inhibitory neurotransmitter. So if this is not being converted to this, far too much of this and can be toxic to the cell. So this is the mechanism known to occur in cats, but there is almost certainly other processes. And in cats, you get signs progressing over a few days. Those focal seizures then become generalized to tonic-clonic seizures, and then they go into full-blown status epilepticus, and then they're very, very treatment resistant. And I'm making that point because in many instances, you have to make a decision about treatment before they get to this stage, because when they get to this stage, they're extremely challenging. What is happening in the brain, and I have to acknowledge the very kind contribution of Abby Crawford and Alexandros Shadras and Sophie Binks here, because they supplied these images, but I just really wanted to show you that this isn't a very inflammatory condition. So we have these swollen astrocytes here, there's gamestocytes, and we have some mild perivascular cuffing. And histopathologically, we show that the blood-brain barrier disturbance corresponds with the MRI changes, but do not correlate or depend on the T-cell infiltrates, which are actually quite widespread through the brain. And it kind of suggests that this isn't cellular, doesn't directly contribute to the neurodegeneration. It's actually the antibodies, which are important here, that are affecting the specific neurons, which makes sense. I mean, I'm saying this is an autoimmune disease that has specifically got antibodies against a very specific part of the cell or in the cell, and it's not a cellular response like you get with meningoencephalomyelitis of unknown origin. And I would suggest that you read this particularly good article which describes that. So big call out to the RVC and Sophie Binks, who's in the Oxford Autoimmune Neurology group. They're doing a study on this, and if you're seeing an affected case, then I really compel you to go to their website, download this form, also of VetMed Uni in Vienna, in very key, that's ACOS there, very, very key personnel in studying these disease. And the more samples that we can get, then the more that we will understand this disorder. Because Muddis, despite having all of this, was actually negative for these antibodies that were tested. He was also negative for toxoplasma and other infectious causes that we know to treat for. And so we still don't have actually confirmation, absolute confirmation in Muddis, but his blood is stored, and I hope that one day we will have that answer. So in humans, these autoimmune encephalitises, because it's more than just limbic encephalitis, are triggered by two main causes. The first is, and by far the most common, is viral encephalitis, especially herpes simplex. And I thought it was quite interesting that Muddis had extension of these inflammatory changes right to the olfactory brain. And you can actually see it here in the olfactory bulbs, and with possibility, that's a bit more doubtful, that it might be extending through the cribriform plate here into the olfactory extension of the olfactory brain through the nose, the olfactory so-called nerve, which is really more like a tract. And it makes you wonder whether he had entry of a virus through his nose that went straight up into his limbic system, which you can just see the bit of contrast showing there. He was also negative for FIV and FELV. Other big cause is tumours, and the two types, paraneoplastic autoantibodies. So this is where you have another tumour, and it has you produce an antibody against that tumour, but it gets confused. Those autoantibodies are confused, and they're very similar to bits in the brain. And then you get attacking of the brain. So the absolute classic is teratomas, ovarian tumours in particular, and NMDA limbic or autoimmune encephalitis. You can also get it from small cell lung carcinoma and thymoma. Interestingly, Muddis did have a mass in the area of the thymus, but this turned out to be a benign branchial cyst, and we don't think it was related. And papillary and adenoma, and actually one study in cats found 1 in 5 cats had this. And then also in humans is biological cancer therapies, again, trying to get the body to attack the cancer can sometimes and very rarely have rather nasty consequences. So I want to introduce you to this is it's not been validated or peer reviewed by anybody else, but I still want to share it with you, my 3-tier confidence level for diagnosis. So this is based on the human literature, and my argument for this is that actually the window for successful treatment is quite small, and it's often cases that you have to make a suboptimal decision for therapy. I just realised I spelt suboptimal wrong there. Apologies for that. The first tier of confidence. So this is not very confirmed diagnosis, but explain the logic, because CSF analysis and MRI are often normal in many cats, and without a rapid antibody test, sometimes this is as good as it gets. So we have those prodromal behavioural changes, then we have those orofacial seizures that are often treatment resistant, and then you reasonably exclude other alternatives. So for example, unremarkable magnetic MRI, you've done an epilepsy-specific brain MRI protocol, you've done CSF, you've ruled out other infectious causes. Our next one is MRI suggestive. So all of the above, and you have also see bilateral medial temporal lobe in the hippocampus changes, and you may or not have paramagnetic contrast and enhancement, and you have reasonably excluded the alternatives. And then finally we have tier 3, so pretty confident, and diagnosis is when all 3 have criteria have been met. All 4 criteria have been met. So we have the orofacial seizures, we have the MRI changes, and at least one of the following, that you've either showed that there is an EEG with slow wave or epileptic activity involving the temporal lobes, or CSF pleocytosis, so changes in the CSF, and you've reasonably excluded the alternatives. If you haven't got one of those, so often the CSF is normal, then really the final diagnosis can only be made if you detect the antibodies against the cell surface synaptic or onconeural proteins. So how is it treated? Well, in humans, they have 3 lines of approach. So your first line is 3 to 5 days of high-dose intravenous steroids, followed by intravenous immunoglobulin. I have to point out, we don't have intravenous immunoglobulin that's licensed for cats. Second line, if there's no response after 3 weeks, then they start plasmapheresis or immunotherapies such as monoclonal antibody and cyclophosphamide. And then third line are these immunosuppressive agents. Treatment in cats is a little bit less sophisticated and much less is known. So most people will start prednisolone, usually at immunosuppressive doses, twice daily, and then it's tapered over variable time periods. There's no consistency. I've wondered about cyclophosphamide, and I've never given it, but I've wondered about it because we do use that is a second line approach in humans, and I wouldn't use it as first line, but I've wondered about it simply because we do use cyclophosphamide in some lymphoma protocols, so it's not, we do know what effect it has. And then of course we have to control the seizures with anti-epilepsy drugs, and we usually need to use multiple drugs to control these seizures. So what happened to dear old Muddis? So he had the prednisolone was dosed initially at 2 mg per kg twice daily and then tapered over 2 months. He had polypharmacy, anti-epilepsy drugs to control the seizures, which was ketamine CRI whilst he was hospitalised, and he also received phenobarbital and injectable phenobarbital and injectable levetiracetam, and he was eventually discharged on these 2 drugs. And the next few weeks can really be described as very rough for his caregivers. He continued to have seizures. They were eventually controlled after 1 month, and they had also had to deal with a postictal neurogenic bladder, which I have to say is quite common in feline limbic encephalitis. However, outcome, he's now living his best life, and he has been really since June of last year, June 2023 now. He has changed. He's comfortable to be an indoor cat. He really has no interest in going outside. He may have some memory loss. I mean, some of my previous cases definitely have had some memory loss, and it does think that he doesn't, he's just not interested in going outside anymore. Maybe that's he's forgotten about it. He's more skittish than he used to be, and he's definitely more noise reactive than he used to be. He has remained an epileptic cat. We've tried to withdraw his medication, and his seizures have recurred. And they've continued to be orofacial seizures, and in fact he continues to have the odd seizure. He definitely needs 2 anti-epilepsy drugs. He's currently on phenobarbital and levetiracetam, but we plan to try to transition him to phenobarbital and topiramate, and the reason for that is that topiramate is a twice daily drug, and levetiracetam is a 3 times daily drug, which is much more burdensome for caregivers and their cats. And so that's Muddis' story, and I hope that he's helped you understand more about limbic encephalitis, just as he's helped me understand more about limbic encephalitis. And I'd like to give a big thank you to him and to his caregivers and everybody at Weir Referrals that got him better. Thank you very much.